Ow. What?
I said hit intro.
Intro. Yes, that's right. It is, in fact, an intro. All right, sweet. So we are, we are here. We had music from Tranquillo. He's on Condina Records. My name's Eli Holland. What are we doing today? Do we? Yes. It's a lecture Q&A, fitness for cool people. It's on the, what do we call it? Oh yeah, studying for the CSPS. Well, it's me studying for the CSPS, not you. I mean, if you want to study for the CSPS, then you can make your own lecture slides, and you can use these for notes. Maybe, I don't know. I may or may not pass. What is a CSPS? It's from the NSCA, National Strength and Conditioning Association, I think. I don't know. It's a. I've got one of their certifications. I'm a certified personal trainer through them. They're pretty reputable. They have normally you'll see from them the CSCS, the Certified Strength and Conditioning Specialist, which is for performance. The CSPS is for a special population, so people that have like the heart disease or the lung disease or the aged or the overweight or coming off, they got like a knee or a shoulder or something, or they're just old or young. Um, so I felt it would be a good way to learn the information, and it's a good certification to get, so that way it can better serve you, the populace. Um, yeah, so that's why we're doing this. Cardiovascular health. I probably should have changed this title. It's going to be much more than part one. Um, I am going to. Here we go. Um, doo-doo, doo-doo. There it is. Let us transition. Fantastic. So, part one, maybe depending upon how long it takes. It's going to take a while. I decided to go through lots of primary research. Lots of primary research. And I got lost reading papers. And it took a while. So here's the information that I did get, and we're just gonna pick all these on up as I continue finishing them out. This one we're gonna learn about heart stuff, myocardial infarctions, heart attacks. We're going to learn a little bit about the health risks and fitness assessments. Not as much with the fitness assessments, that's toward the end. Programming needs, that's what the next lecture is going to be on. And there'll be an example of why. And then the other thing will be knowing your role, monitoring the clients, and referring to physicians. So, a CSPS is, I don't know, a glorified coach that can work with diseased people better than someone who's just part of the general population or just a certified personal trainer. Their job is to be able to work with physicians, specialists, and primary caregivers, and be able to help organize strength training and nutrition, because doctors actually doing programming strength training, resistance training is outside their scope and field. I mean, yes, they can recommend it, but they actually don't have like sufficient medical training to program something for general strength, or nutrition or diet for that matter. That's up to registered dietitians in the case of strength training, certified personal trainers, or, excuse me, in this case, CSPS. So there we go. Here are the ones that we're going to be going over the next coming weeks. Myocardial. God, that's gonna be awful if I keep mispronouncing that. Myocardial infarctions.
You'll sleep more next time.
Myocardial infractions. uh,
Infarction.
Infarctions. Yes. Um, Angina, hypertension, peripheral vascular disease, congestive heart failure, valvular disorders, revascularizations. We touch on that briefly here, but it'll be, hooray, saved for another lecture. And then conduction defects and disorders. Ooh, okay, so this is a list of all the primary research that I used. I didn't do the best job sussing out where I got what quotes from and so forth, but it's all up in there. They're all right there. So you can get the slides, you can take a look at them yourself. And so this is the ones that are starting for strength training. So this is how far I got. That should have been edited out. This slide will be changed. Let's get down to business. Myocardial infarctions. MI. If you see MI throughout this presentation, that's what it means, myocardial infarction. Basic terminology. An infarction, cell death, so necrosis, like frostbite or gangrene or leprosy or something like that. It's due to a lack of blood flow. Necrosis as opposed to apoptosis, which is programmed cell death. Necrosis, or if you throw like chemicals on it or you burn something, it just dead cells dying from a variety of different ways, and it's not good. So myocardial infarction then is the death of heart tissue, specifically some myocardial muscle, myocardial heart, death of the heart tissue due to a lack of blood flow. So let's take a look at the picture. We got our heart, and the heart muscles need oxygen for them to be able to do their thing, which is pumping blood to the rest of the body. And we take a look at one of those red arteries, coronary artery, and look at it in cross section, and it is clogged with fatty deposits. And them fatty deposits are stopping the blood from getting through. And when that happens, we have the myocardial infarction. Ischemia is a restriction of blood flow to the tissue. It results in the lack of the oxygen being delivered and an inability to clear metabolic waste. So that's kind of interesting as a corollary when if you're doing like high rep metabolite work in like the 40 to 60% 1 rep max range, this is kind of the mechanism that's actually being delivered as a stimulus to the muscles, right? You're lifting to the point where you can't contract them anymore because of hypoxia and lactic acid and other metabolic waste being produced, and that based upon blood flow restriction training, that is potentially a mechanism in of itself to deliver hypertrophic stimulus. So that's interesting. It's an interesting corollary. In the heart, it's bad. You don't want to have that in the heart. Coronary artery disease. So it's a variety of diseases that affect the arteries that feed the heart. An infarction is a type of coronary artery disease. Another one, coronary thrombosis, so a blood clot. It's a formation. So blood vessels get damaged and they start to bleed. Platelets will go to the site to have it coagulate. And if those, that's a thrombosis, and if those get large enough to separate and move, then you can get an embolism. Now, an embolism can be any sort of either air bubble or a fat pocket or anything like that that blocks off a blood vessel. And the old side thing like, oh, what happened? Oh, there were spiders in there.
Well, that's what the Warframe gun, the Embolist, does. It puts spiders in.
Yeah, great.
No joke. I crafted one like 2 days ago.
That's great. the spider arachnobolisms. If you have an embolism caused by a blood clot, a thrombosis, it is a thromboembolism. Perfusion is the restoration of blood flow to tissue. So we'll see that term comes up when discussing the types of heart attacks, as well as some of the EMT and medical techniques and stuff that are used. We're not going to go too deep into those. It's outside the scope and field, but in doing research, it's amazing what they're doing in those ambulances, trying to save our dumbass lives. Fun fact, myocardial, it is the leading cause of death worldwide. Approximately 40% of the deaths in developed countries. I read a couple papers, one about Iran. 70% of all the deaths in Iran, according to that research paper, that meta-analysis, are from heart attacks, and which is really scary to think about. And the leading cause, unfortunately, was the time from injury to hospital was, with a 95% confidence interval, 9 to 13 hours. And that's a very, very critical sort of time for something as life-threatening as a heart attack. In India, 31.7% death rate, or not death rate, 31.7% of the deaths in India are caused by myocardial infarctions. The Indian population is, due to genetic and lifestyle factors, apparently 4 times more prone to myocardial infarctions than the world average, and they have seen a dramatic a 5-fold increase in heart attacks from 7% in 1970 to 32% in 2011. That looks like industrialization ravaging a country. In the U.S., paying for it in medical care costs us $100 billion a year. It is the leading cause of disability in working populations worldwide. Just in the United States, we lost 90 million work hours just to heart attacks. So in the rush, okay, crap, we got to get these people back to work. Studies have shown that too quick a return results in lower quality of life, reduced outcomes, aggravation, and potential recurrence for myocardial infractions. God, a myocardial infraction sounds like something that happens on a football field or something like that. Myocardial infraction. And God, holy hell.
You need to sleep more before
let's just I gotta sleep, full stop, but we'll get but this is, I mean, is this not informative?
It is.
It's
you
fairly.
You just gotta say it less stupid.
Come on.
Not on the slide, but
we can do stupid.
Yeah, I suppose that's the theme
today. I can make smart person words. Okay, so let's talk more about what they are. An acute myocardial infarction. That's the one that we're most used to with the heart clutching and stuff like that. So it's defined as an irreversible myocardial injury of greater than 1 centimeter. That sounds like a huge chunk of organ tissue to be damaged. I opted not to put a picture on here, but they showed one in cross section where there was a heart attack injury and a lesion, and it looked like, I don't know, the piece of like a quarter or like a silver dollar, something like that, of just like dark red. Time scale less than 3 to 5 days old. And then there's two types. So again, perfusion. So there's reperfusion and non-reperfusion. So in the reperfusion one, there's an obstruction, but it's removed within a few hours, and the blood store is restored after the cells have died. So that part's not great. And I guess it ends up meaning that you survive it, and it may or may not be one of those silent myocardial infarctions. God, and each one of the slides is missing an O because I just kept copying it. And so eventually it'll get spelled right. Myocardial infarction. It's like a Hasbro toy.
Myocardial infarction.
Yeah. Non-reperfusion. It's a lot more dangerous and probably has a higher rate of mortality, given that once it gets obstructed, it's permanent. That's not good. They originally, and some people still classify them based upon, let me phrase it, it's still classified by electrocardiomicrogram. But the classifications of STEMI, either ST elevated myocardial infarction or non-ST elevated, which is part of the ECG that comes after the Q wave. We'll see in the next slide that those terms are kind of outdated. Being able to diagnose a ECG is outside the scope of a CSPS or a personal trainer. So if you are getting a personal training and the person asks to look at like your ECG or any other like, private personal like medical history information, get a new personal trainer. Let's see. So here are some of the things that happen during an acute myocardial infarction. So blood pressure dysfunction, drop in stroke volume, so how much blood is being moved by your heart at any one time, irregular heartbeats, dyspnea, what was that? I believe that's faintness. I have it on the other slides. Anyway, we'll talk about some of this stuff. Just brief. There's a lot of stuff that goes on when you have a heart attack on a cellular level. So new clinical classification of infarctions. So this came in 2007. The third definition, through universal definition of myocardial infarctions, came out in 2012. It's broken up into 5 different categories. Type 1 was what we saw before, plaque plugging up coronary valves, usually severe coronary artery disease, though it is not necessary to be present in order to identify it or clinically define it as type 1. Type 2, it's not coronary artery disease related, though coronary artery disease can be present. There's either an irregular heartbeat, blood pressure drop, edema, some other mechanism besides it being clogged up with plaque, though also in addition to it could also be plugged up with plaque. And we'll see that that's kind of a problem, that there's difficulty with those two definitions. The type 3 is a cardiac death suggestive of ischemia, but they can't obtain the biomarkers. So as we saw previously, let's go back to the slide, make sure I get it right. There we go. So acute myocardial infarction. So that can be detected within 3 to 5 days as being acute. But there is a window by which the biomarkers or the ECG won't necessarily detect that there was insult to the tissue, but it can be suspected. Maybe there's some sort of imaging that can be done. And then types 4 and 5 are specific to surgeries associated with revascularization, which means we'll talk about it briefly in revascularization. So again, talking about that giant chunk of tissue that I saw that was damaged. So an example, 25% of the or more of the myocardial tissue can be damaged in like the left ventricle, and that's significant because that's the one that pumps all the blood throughout the rest of your body, all the oxygenated blood. So if that gets like whacked like really hard, you can see how the stroke volume is going to decrease and how everything is going to go tits up real fast. So there's yeah, you know, like a dead animal. Or oh, it's what was it? It's fen fungus. He'll be rotting belly up before morning. Okay, so one of the interesting things too in reading is that the tissue, the death to heart tissue, the necrosis and apoptosis, it is somewhat reversible. And a lot of that depends upon how fast the tissue gets worked on and what sort of techniques are used and available. But as much as it's estimated 30 to 50% of the damaged tissue can be saved or repaired. Again, based upon the variety of modern EMT techniques that can be used. The downside, though, is those same EMT techniques also cause what's called perfusion ischemia injury, and so it damages it while it's trying to preserve things. I read a paper on therapies that talked about potential therapies for taking care of the tissue. One was stem cells, one was treatments that improve the apoptotic clearing. So when necrosis happens and the cells die in that matter, as well as a lot of apoptotic product but not being able to clear, then scar tissue forms. And when the scar tissue forms, you don't really get the regenerative myocardial growth that we're looking for to restore and improve function. So there were those two, and then the third mechanism of experimental treatment escaped me beyond the stem cells and apoptotic clearing. But it's really interesting that there's research being done at that level, and hopefully there'll be some sort of help for it, because given how prevalent myocardial infarctions are and how there's, again, it's it's either 6,000 to 1.5 million of them in the United States every year, and like 15 million to 20 million people die every year worldwide, and so countless other people are wounded by it. Like getting good treatment to actually fix it right, real deal fix it, is critical. Especially because of how much money it's already costing us and all the labor hours that it's costing us, so we're not really getting anything out of it. And then the double whammy. So after you get one, you're actually 30% more likely to get another one. I should have put in those charts, but we'll talk about them with risk factors that, depending upon the type that you have, whether it's type 1 or type 2, and other risk factors, your rate of mortality, it decreases significantly faster. So in 2013, there was a paper that was, so again, 2012, the third iteration of the universal definition of myocardial infarctions was created. And then in 2013, this paper, I guess leveraging off of that, found some novel biomarkers to try and find actual novel definition or actual mechanism to detect type 2 more definitively. But the problem is, because there's, so both type 1 and type 2 coronary artery disease can be either present or not present in both, and it's kind of a definer, but it's also like up to the clinician. And type 2 had so many, it's based upon like blood pressure issues and irregular heartbeats and stuff like that, irrespective of things being clogged. It's very difficult, and so they're trying to find something that could definitively do type 2, and there they did 2013, no mechanism. 2015, they looked at it as like, well, we don't have a mechanism, doesn't matter given the severity of myocardial infarctions in general. Another paper demonstrated, 2016, type 2, they have poor outcomes, I think 3 times the death rate as compared to type 1 on follow-up. They have longer stays in hospitals, and they use more resources, and they have poor outcomes. And so it becomes, not to talk about, I don't mean to talk about life in such a callous sort of manner, but it becomes a real big like resource drain for something that has even really poor outcomes. And so it's critical to be able to define type 1 and type 2 and be able to come up with research and therapeutic techniques specifically for type 2, so that way we can help people that are much worse off. The paper showed the risk factors for type 2. They were older, they had higher prevalence of diabetes, and a couple other statistically significant and biologically relevant data was generated. So in 2018, so just this year, a Swiss paper showed they still don't have a reliable test mechanism for type 2. Based upon the current definition, there's only 55% consensus, and for agreeing, I think it's 55% for agreeing for type 1, and 67% for, 55 for type 2, 67% for type 1, and that's not great. 55% on type 2 is only slightly better than the coin flip. It's like a pair of 6s over queen 10 suited. Actually, I think that's only 53%. Anyway, and then for where it's relevant then to personal trainers and CSPS is that because type 2 is covers a much larger swath and poorer outcomes, and the people are in much more difficult positions, that makes our job more difficult finding stuff that's going to be able to challenge them. But at the same point, it's not going to kill them, because there's plenty of evidence to show that exercise, when people have myocardial infarctions, can cause another insult, especially given that I was saying that like the burnout mechanisms for like doing metabolic weight loss is ischemia, the thing that was happening in their coronary arteries. All right, so here are the symptoms. They're I think a lot of the classic ones that we see whenever the symptoms are portrayed on TV. So the intense chest pains may radiate referred pain. It lasts for like 30 to 60 minutes. Substernal heaviness, so right here. Squeezing, pressure, aching, burning, or even a sharp pain. Chest, shortness of breath. That's what dyspnea was. I forgot what it was.
Like apnea.
Yeah. Now, no, I needed to take that out, or I believe I put it on there. But while acute myocardial infarctions can happen anytime and randomly, apparently fatigue in the days and weeks preceding, as well as malaise, and there's one more, I think it's on the next slide, that if you already have like a few risk factors for myocardial infarctions and heart disease, you or the trainer keep an eye out for these sort of things, and like greater than normal fatigue or malaise, and then maybe refer off to a refer off to the primary care physician to have them checked out. Let's see. Fainting, nausea, sweating, anxiety, sleeplessness, hypertension, or hypotension. So that graph that I showed earlier about all the different things that happen during a heart attack, and there's much more intense with even thicker medical jargon that talked about why hypertension and hypotension can happen based upon the extent of the heart attack. Irregular heartbeats, and epigastric, full of gas sometimes. Who knew? Now, women. So this was interesting. So there had been a fair amount of studies trying to elucidate if there are any differences between men and women in either the symptoms or the risk factors or anything about the population, so that we can better predict heart injury and or help with the symptoms and get people the help they need. So what was found in a meta-analysis, and seen this in a couple of papers comparing men and women, as well as a meta-analysis specifically on women and heart attacks. So the chest pain was less common. They had symptoms more of weakness, fatigue, and dyspnea. And essentially, because of that, and the this difficulty they found interpreting the severity of the injury, and we'll skip to this one, and it kind of explains this. They were at increased cardiovascular risk attributed to psychosocial distress is similar in men and women, but women are more prone to psychosocial distress. Their burden of disease is greater. Psychosocial, that's society. So because of the societal stress that is put on women, they are at increased risk of heart attacks. And because of how they bear the stress, they are having difficulty interpreting the severity of the injury, delays in seeking medical attention, and or will self-medicate before seeking medical attention. However, they said it was found that the greater the severity, the more likely they were to get treatment. However, these two things right here, if you remember from the previous slides, that getting treatment within 12 hours is critical in terms of being able to save the heart tissue. So if we could end up having a situation more common in women, I would suspect then, where they're having a lot of the silent injuries that are happening, and they're either being underreported or nothing's they're not seeking treatment because it isn't severe. It's only when there's a big one where it actually I guess does enough to really jolt them, do they actually get treatment. So this has implications for personal trainers when they're working with women versus men. The true diagnostics for determining whether a heart attack has happened. So again, this is for medical professionals and doctors and specialists and so forth. But I thought it was interesting. And actually, there's one down here, the exercise stress test, that while personal trainers don't necessarily have access to this sort of equipment, it would be something that would be more attainable for them to do, even though there's an actual assessment that we'll see later. So troponin, again, it's only released during myocardial cell death, and it has a latency where it can hang around for a few days. I don't remember how long it was. I wasn't interested in looking at the sensitivity of troponin. But it is able to detect silent myocardial infarctions, but then you get to the point in the case of like type 3s where there aren't any biomarkers available, and so you're just kind of guessing or assuming based upon other symptoms that yes, ischemia has occurred. Electrocardiogram, microgram. It's the gold standard. Looking at the heartbeat waves. That's again originally how they had the ST elevated or non-elevated myocardial infarctions. And then the exercise stress test. So it's a graded exercise test over 20 minutes, where the person is hooked up to the to an ECG and blood pressure, and as the intensity and slope and resistance increase, and they get pushed into higher predicted heart rate, they gather information about it, and then that can be used to detect an injury, if it's to detect to see if there has been an injury or if there is disease, or detect the extent of the injury. It's not quite as good as some of the ECG measurements. I guess again, this is kind of outside my scope, but I thought it was interesting that these multiple different tests existed to rather definitively kind of define whether someone had a myocardial infarction. So here are the risk factors. So these are things that are relevant to personal trainers and fitness professionals, because this is information that can be gathered, and based upon this information that you get from them, you can determine what kind of risk they're at, and how in danger they are from doing exercise. And then you can start seeing, okay, what exercise can or can't they do, and what things can we try and change if possible in order to reduce their risk factors. So two papers describe them as being both non-modifiable and modifiable. The non-modifiable ones are age, and particularly they started the cutoffs at 45 and 55 is when the increased risk of heart attacks occurs. Though the range that I had seen for men in one study was the age of 29 to 99 years old. So, excuse me. Wasn't it on the Late Show? John Cleese talked about during Fish Called Wanda that a man died laughing, having a heart attack. Yeah. So there you go. So that was hopefully that guy was 99 and at the end of his spectrum.
No,
there.
I think he was one of the actors or one of the people from the film.
Was he? No.
I think so.
No, it was no.
I think it was just some random person that died laughing.
Yeah, that's what I recall from the. It was just on Stephen Colbert. Anyway, so 6 to 10 years later, and it's suspected the reason why is the higher levels of estrogen have a some sort of cardioprotective effect. Potentially better fat distribution, healthier fat distribution. I'm not sure if they were talking about the types of fat in the body, though I suspect they were talking about where the fat sits in the body, the difference between pear-shaped or apple-shaped, or the subcutaneous versus visceral fat, something like that. These differences are attenuated following menopause. So I guess then that's what that 10-year buffer right there would be. Without menopause, then who knows? Maybe without menopause, women would be even more protected for heart disease. Interesting thought. Genetic factors and autoimmune diseases, those are things that you can't change.
Well, it's not just estrogen, because estrogen produced by large amounts of adipose tissue doesn't make your heart healthier.
Oh no! Okay, no. So I had this conversation earlier. It's not that. So it was said then. Okay, so if you remember from the phasic approach, right? We said that fat is a member of the endocrine organ, and it produces estrogen, and that has all sorts of health implications. So that's there's a contradiction there. If you have more fat and you're producing more estrogen, then shouldn't it help protect your heart more, even though we know obesity is a major risk factor? So this is in relationship between men and women. I'm not sure what the estrogen difference between someone who is a female who is normal sized versus obese, or even obese versus morbidly obese, what the estrogen difference there is. I expect it to be in that range. The differences between women of various body sizes and their estrogen production, the difference there would be smaller than the difference between estrogen production between women and men. Um, so, while more estrogen is better, more body fat is not better. Also, women tend to naturally carry about 10% more body fat than men, and that's producing estrogen. So, it kind of all ties together somehow, I'm sure. Modifiable. This is where personal trainers and doctors can apply leverage. Smoking. Numerous papers showed the India paper, the at least one of the papers from Iran, and I'm sure you can find all sorts of papers in America. Smoking is a major risk factor for heart attacks and cardiovascular disease. Activity levels, so not being active, risk factor. Psychosocial stress, again, I put that as modifiable because that can be changed. That women have so much pressure put on them in society, and I'm sure if we looked at those studies even further in the United States and looked, I'm sure the risk is even stratified greater on women of color and other people of marginalized populations. This is modifiable. We can change this. Type 2 diabetes. You can change that. It's diabetes, but specifically type 2. If you got type 1, then it's over here because it's an autoimmune disease. But type 2 diabetes, mostly preventable. Risk factor. High blood pressure. Risk factor. Also a genetic component, but highly modifiable through strength and diet and weight loss. High cholesterol has a genetic component. So this was interesting. Some papers said like, we're not really sure about cholesterol because it has such a strong genetic component and it waves around. But most of them have essentially alluded to cholesterol is a problem, and irrespective of whether it's a what am I trying to say? It's not necessarily a function of dietary consumption. It's more a function of genetic consumption, genetic production. And it's better to have a higher HDL than not have higher HDL. But they're not 100% sure how big a deal cholesterol is as much as overall high triglycerides. However, what they found is that smoking gives you the double whammy. So not only does smoking cause damage in and of itself, but the way it mediates and reduces HDL and increases LDL then starts to really help build up some good old arterial plaque. Mining for gold and them their arteries. Metabolic syndrome. The trifecta: high blood sugar, so insulin resistant, high blood pressure, the hypertension, and the obesity. So it is so prevalent they had to give it its own name. Stress and drug use. Those can be changed. That's where personal trainers get to leverage. And the same point, those also have to be asked. Like, as a personal trainer for your health and fitness, like, risk assessment, it has to have those sort of questions on there.
How is psychosocial stress different from stress? Or is that another lecture?
Yeah. Psychosocial stress is different from just regular stress, because there's a variety of ways the individual can put stress on themselves, for example.
True.
Or there's actual physical stress being put on them by something smashing them or something like that, or not being able to. But psychosocial stress, it's societal versus just the individual. Could be individual interactions that just give you stress. Like you could be at the top of your profession. You know the people that are at the top of them high rises, and then they die of heart attacks. Assessments. So I spent all that time looking at like all the clinical stuff that I didn't quite get around to the assessment. But so this is where we're gonna go deep into it next time. I had about 25 papers queued up to go through to figure out all the fitnessy sort of stuff. But this is a prime example that I found just looking at one of them. So they found for people that were recovering from coronary artery disease and specifically myocardial infarctions, the intermittent shuttle walk test. So again, 20 minutes of graded walking. It sounds kind of similar to the exercise stress test, but I guess you don't have all the other stuff hooked up to you. And they've suggested that there's some sort of learning aspect, and that's why you do 2 bouts. But they found most people that they tried could only make it 15 minutes the first time anyway, so you don't really need to do another test. But it's just to see basically, I guess, how much you can push the person and what sort of level of intensity with walking and stuff, and at what heart rates do the wheels start falling off and they start becoming symptomatic of bad heart stuff. Bigly. Anthropometric data. Hi, I'm Hardy the Heart. Blood pressure, heart rate, that you get from their doctor and medical records. Heart rate, you could take their girth measurements, their cholesterol levels, triglycerides, alcohol, smoking, etc. Some of those would require medical clearance, I believe, from a doctor, like the cholesterol and the triglycerides and their blood pressure. These heart rate's acute, girth measurements are acute, cholesterol, triglycerides, these are kind of good to know. We can't do anything diagnostic with them by looking at them like, oh, based upon your this and that, fucking, I'm a quack doctor and I'm going to work outside my scope. And I'm going to make some shit up so that way you give me money. Not quack doctor, quack personal trainer. But they're good benchmarks to have so that way you can know as a measure of progress when you're doing exercise with the individual, especially if they're larger and there might be more inaccuracies with girth measurements. You can take a look at the cholesterol and triglycerides as they've changed, because we saw that those were risk factors and very good markers for improvement of myocardial health and overall health. And then figuring out where they're doing the alcohol and the smoking. I saw one paper that showed if you're smoking after you have your myocardial infarction, you are really exposing yourself to even worse risk, and you're just piling bad on bad. So we'll have a few more assessments in the next slide, or in the next presentation. Programming needs for clients. So this is another thing that's pretty critical. Now that we've learned, a little bit about myocardial infarctions and what they've actually kind of doing to the body, how can we come up with a program that's going to get them the results that they need, which is strength training, losing weight. We know that all sorts of strength training as cardioprotective benefits and does wonders for the heart, and doctors and all sorts of people are more than happy to tell patients to go get like strength training exercise and stuff like that. But the problem is, how do we manage them? Because if they've had a heart attack, they're at risk for more heart attack. So the way I'm going to go about this is I'm going to examine research specifically on strength training and cardio trials for people that have had myocardial infarctions. I'm going to look at the inclusion and exclusion criteria for people in the study. And the reason why I'm going to do that is so I see a paper, I can see in their materials and methods if it's a good paper, which means it can be reproduced. It shows what sort of strength training or what sort of aerobics or cardiovascular training program they were put on, or what this study was trying to test. So we can look at a few of those and see what patients they felt, or what sort of clients or test subjects essentially they felt comfortable training with that plan, and then I could apply a similar sort of plan but fine-tuned based upon the background that I have with strength training and stuff for the general population using MRV and fatigue management and stuff like that, to get something that is really customized specifically for the population, that I know from empirical evidence is going to be safe for them. That sounds pretty smart to me. So one of the examples, there's a paper from, I think this one was from 1998. There was one that I had read from 89 and I think 98. So this was with the question was strength training following an acute myocardial infarction. So these were the inclusion criterion. 23 men within 6 weeks of a heart attack without exercise-induced ischemia. So that means that they're able to exercise without blood flow being cut off, complex arrhythmia, so irregular heartbeats, ECG stuff, other science stuff and medical stuff that I don't know. So, but that gives me information that they're okay training people where things were stable within 6 weeks of a myocardial infarction, and where the exercise wasn't going to cause more damage. I know that kind of seems a little bit like a self-fulfilling prophecy. How do we know the exercise isn't going to cause ischemia unless we do the exercise? I'll have to read it. Again, this is just a brief sample that I looked at. They looked at strength training and VO2 max increases, and they found that with the strength training and the cycling, they had significant increases in both upper body strength and lower body strength and VO2, better than just cycling. And this was in 6 weeks of MI. So hopefully you can see the training protocol that they had and see how good it was or gimpy it was or whatever. Another example, patients were excluded from the study for the following. Again, uncontrolled arrhythmias, so complex uncontrolled blood pressure makes sense. Diastolic blood pressure hit. Whoa, yeah, that's the bottom number. That's not dope. Less than 3 months in PACE. I believe PACE was a patient an outpatient group for the study, but again, have to look at it. Exercise capacity of less than 6 METs. So METs is this cardio machine equivalent measurement that is used basically to compare the treadmill to the elliptical, to swimming, to biking, that sort of thing. It was a way where they kind of brought it down to some sort of universal unit, so that way they could compare them. I'm not sure. Anyway, I don't really come across it that much because most of what I focus on is strength training. But a lot of research with disease populations historically has been with cardiovascular, because they were worried that strength training was going to be too much for the people, and it's been only over the last really 1 or 2 decades where it's like, oh, holy shit, strength training is probably better. Anything is good. I think that strength training is probably better simply because of the volume. It's so much easier to get the volume in as opposed to just walking and, everything's great. Especially for people that need it. What else? 6 mets on a previous stress test. So again, there we are, that exercise stress test. So that was applied in a sports and research sort of setting. Or recent history of congestive heart failure. And they found 43 men with the mean age of 55 plus or minus 8 years, 35 to 70. Oh. That bottom end scares me. That's why we do the strength training. Informed consent to participate in the study. So there we go. There's inclusion and exclusion. As a personal trainer, I could then take a look at a few more of these and then come up with my own criterion, at least for myocardial infarctions, what would be appropriate for them.
Just paste the program for all-inclusive care of elderly. That paste?
Yeah, could be.
That's the only paste I'm finding.
It could be, was it the program of all-inclusive care for the elderly from Medicaid? That could be it. PACE could also just be like a government program, and that other PACE could be some technical jargon within the research field or something like that. But it's could be. I mean, I've got the source for it. I can find it. Do I have more? If I click here, no, I don't have any more. 16 slides. That's a short one.
Yeah, 1 hour.
1 hour. All right. Well.
Is there anything else you want to cover?
Oh goodness. I mean, there's always stuff I want to cover. But I think I'm going to call it so that way I can eat, I can look at some more papers, I can sleep, I can get ready. Oh, we got another one. So Culinary for Cool People on Sunday, 8 p.m. Salt your meat, learn how to brine and cure, and learn a little bit about marinades and bastes and things like that. Should be fun. That's it. Hope you folks learned something. Yeah, we're going to add to it. Pick up next week on Thursday. Oh, yeah. No. There we go.
Yeah.
Hey. All right. We're learning things. Anyway, yeah, so Culinary for Cool People, 8 p.m. on Sunday. Meat prep. And then next Thursday, we're going to pick up here. So we're going to go in deep on the health and fitness assessments, programming for, exercise programming for people that have had myocardial infarctions, and how to keep an eye on them, and when and how to be in contact with the doctor and medical personnel to make sure they stay safe. So, on that, I'm gonna stay safe. I'm gonna get some more beer. Outro slide. All right, fam. We're out of here. Take care. Sweet. What'd you think?
You need to sleep more. For the most part, it was just those typos, slides, and that one hanging bullet point.
Yeah.
So you kind of started the slides with that.
Was the
Talking about
what was that? Okay.
aren't quite as many, and then
No, it's fine.
symptoms at 35 minutes, and then
Risk factors.
I had 53